Good morning, ladies and gentlemen. Welcome to the Going Remote Healthcare Delivery in Delivering the New Normal webinar today. I'm John McLaughlin. I'm one of the directors here for Consultations. I'll be your virtual host briefly this morning before we hand over to the team to start with the content. Just want to start off by saying thank you all for taking some time out to join us today. As stated in the title of this webinar, we're all getting used to the new normal, and I know that time is of the essence. But we also need to be concentrating on self-development and hoping that today's conference will provide you with some high-value insights into going remote and implementing the new normal for us all. Just a few very, very basic housekeeping rules. We are in for a very short but content session. So make sure you've got your teas and coffees ready. It's about an hour or so long with some nice Q&A towards the end. I would advise you all, please, if you can, to familiarise yourself with the dashboard, and in particular, the questions drop down. So you will have multiple different options on the right-hand side, guys. So you've got webcam, audio, dashboard, attendees, polls, and chat. If you can all navigate to the questions drop down, if possible, you can extend that box on the right hand side. You will see a little box with a slash through it that will extend any of those boxes. So if you can all navigate to the questions section for me, and if you might just drop a quick Y in there for me, or a hello, that would be great. Or just please let me know, what drove you to come to this conference today, and some of the key takeaways you're looking to gain. Hi Patrick, hi Dean, hi Catherine, hi Dave. Thank you very much. Shirley, Janine, Jane, Joe, thank you very much again. Good morning, Simon. Good morning, Sarah, Anna, Peter, Sam. It's like being back in school again with the register. I hope you're all holding your hands up there. I won't continue to name everybody that's saying hello, but thank you for that, guys. Andrew can't hear audio. Andrew, the event is live, the audio is fine, so please have a little look at that control center for me and make sure that the microphone and the camera are on green and not a nice shade of orange. Thank you, Kevin, David, Nicola, Amanda, and Mandy. Thank you very much. Right, Martin, I think I've warmed them up for you a little bit there, sir. Hope that was okay. How are you today?
Yeah, really good, thanks. Excellent. So it's a pleasure to be here today.
Yeah,
nice
we've got a good audience.
Sunny day down in Berkshire. So I hope it's good where you are.
We've got good weather for ducks generically in Manchester and Stockport area. So they're the only people that benefit of ducks, really. Only things that benefit of ducks, sorry. But yeah, looking forward to today though. Great subject line, really, really current, and something we all need to be hearing and listening from, Martin. So pleasure to have you involved.
Right, great. Well, I think we'll get rolling then, shall we?
Yes, let's go for it. Martin, I will jump out. I'll be in the background anyway, and yeah, leave you to it. But thank you again.
I'll call you in for the polls, yeah?
Yes, please do that.
All right.
Cheers,
Thanks
Martin.
a lot. Right, well, welcome everybody, and it's a pleasure to be with you here today, and our colleagues at Consultations. So let me just bring up my screen. Hopefully you can all see that. So I'm Martin Taylor. I'm Deputy CEO, co-founder of Content Guru. So I head up also our healthcare practice. So I'm told that this is an audience primarily of IT and communications heads in the healthcare space. So it's very much focused for you. If you've wandered in from another sector, we might be able to help you there too, but we're very much on the healthcare front today. So in the healthcare team, we've got clinicians, we've got engineers, we've got project managers, we've got operations people. So we've got a complete suite of capability and of course a great platform for running these kinds of healthcare facing services. So I'm going to be co-presenting today with Andy Lord. Andy is from Sussex Partnership NHS Foundation Trust. It's one of our mental health customers in NHS. So Andy's going to be talking to you about some of their challenges through this age of COVID. So let's just look quickly at the agenda now. So firstly, inevitably being 2020, I'm going to talk a little bit about coronavirus, specifically how it has impacted how we communicate. And then secondly, a brief introduction to Content Guru. I'll try not to dwell too long on that. And then from there, we're going to go into patient engagement ideas for around the age of COVID. And now with vaccines coming, we're looking at the post-COVID era. But I maintain that a lot of what we've learned in this COVID period, things that have advanced around video, around how we communicate, we're not going to unsee that. We're going to have to carry that forward. Then the exciting part, we've got Andy talking about SPFT and some of the interesting things they've been faced with and how they've dealt with them. And then we're going to go on to some Q&A. So Sean directed you to the Q&A panel, which is over on your control panel there on your screen. But also we're going to be covering some poll results. So actually, I'm going to bring Sean back in shortly because we're going to do a couple of live polls first. So we've got a good amount of you here on the session. So I think we'll get some interesting results. So the first poll, and there are going to be two, and we're going to get the results of those polls after Andy has spoken, and then we're going to discuss those. So the first is, which of these has been the biggest challenge for your organization during the coronavirus pandemic? Was it the immediate need to invoke home working, possibly in an environment where you haven't had home working previously? Was it increased complexity of patient inquiries because people were having to ask you things remotely that you would normally be dealing with in person? Was it increased volume? We certainly saw a lot of increased volume for a lot of our health sector customers, particularly early on in the run up to lockdown one. Or was it the need to reduce in-person contact in care delivery because suddenly seeing people was more dangerous? So immediate need for home working, complexity of inquiries, increased volume of inquiries, reducing in-person contact. So Sean, perhaps if you can make the poll live. So let's get voting.
Ready to go.
Yeah, good. Well, let's get voting. Feels a bit like Eurovision or something here. Okay, so I can't see your votes, but I'm assured they're coming in.
There indeed.
Yeah. Well, we'll just have a look at them kind of at the end, I think, Sean.
Okay, not a problem at all. That should be okay. Matt's controlling it on his end, and I'm not sure. Matt, when you close the poll off, Matt just automatically share the results you see, Martin. So we'll have to see.
Nearly at full capacity now for the voting, everyone. We will share the results at the end.
Okay, great. Should we close that poll now and then move on to the second one? Right, so it'll be really interesting to see what you've come up with for that. So the second one is reactions to coronavirus. So which of these options has your organization found useful for limiting person-to-person contact during this time of coronavirus? Was it going to voice calls? Was it video consultations? Has it been waiting room queue management so that you haven't got people gathering together and causing each other an infection risk? Or has it been digital self-service options? So voice calls, video calls, queue management, or digital self-service. So the poll is open. So let's give you a moment to get yourselves voting in there. Again, it's going to be very interesting to see from this quite wide range of organizations here, which are the favorites here: voice, video, queue management, or the self-service. Right, are we about done on the polls now, do we think?
There we go.
Yeah, excellent. Right. Well, thank you very much for that. And we'll run over those a bit later on and discuss them. So the next point we're going to go through is around coronavirus and what did that do in terms of patient engagement. Certainly, it's caused a lot more patient engagement inquiries. I mean, we had one received from a private hospital group yesterday, and suddenly they want an RFI quickly on a patient engagement system. So patient engagement just really wasn't something you were hearing a massive amount about on a day-to-day basis until about March of this year, and suddenly it's centre stage. So what happened then was this need to reduce infection risk, not just nosocomial being in hospitals, but anywhere really where people gathered together. It became risky to see our patients, whether we're in primary care or we are in secondary care or any other healthcare setting. So short term, we had to move quickly. We tended to replace in-person visits with voice calls. So let's have a phone call. And you can do a lot on the phone, but you can't see people. So that made diagnosis harder. It generally reduced that patient to clinician contact and accuracy a little bit. The second thing we did was we wanted to stop people gathering together. So email alerts to say if they did have to come in, let them know when to turn up. So that's very sensible. But again, you have to receive that email. And again, if you've got an email and it's saying maybe come in to the emergency department at 3 o'clock this afternoon, and you think, great, I've got an appointment at 3 o'clock. I'm going to come in at 3. I'm going to be seen immediately. And then you turn up at 3, and in between 11:07 and 3, a lot has happened. Lots more urgent cases have come in, and you find yourself waiting around till 6. Whereas, because if it had been dynamic and you'd been told and updated as you went along, rather than just having a static alert, then you could have avoided perhaps that 3-hour wait and infection risk. So there were some short-term solutions, but still going to be that need in the longer term. So longer term solutions have emerged over that time. So video call functionality. So you can have a video consultation, either a booked one or ad hoc. So you can see as well as hear. So that's been something that was brought out very, very quickly and has now become established and popular. I mean, it's something we had talked about with healthcare organizations for years. And there were always IG reasons or other reasons. It was felt patients wouldn't engage with it. Clinicians perhaps weren't too keen on it. But now one-way and two-way, that's become well established. Virtual waiting rooms. So rather than just a static appointment, you're actually in more of a queue, which certainly reflects a kind of urgent care setting. But equally, if you've got an appointment at radiology, ophthalmology, or any other department, you could still be waiting around. So trying to rooms, but on a dynamic basis. There's been this focus on more increased complexity of patient communications and automation of them as well. So we're tracking DNAs, making sure that we're keeping people updated. And of course, we've got a bigger list of vulnerable people who we're supporting in their own homes. So we're needing to reach out to them. And again, automation has had a big part to play there. And then generally, we've got the rise of digital collaboration tools. So we're seeing it across the spectrum. One thing that we're working on, for example, at the moment is an MDT tool, a multidisciplinary team tool for the care home sector. So that GPs can do a virtual round, care home staff can update records on the go, and everyone is kept up to date through digital collaboration, much as we've used things like Teams in the back office setting. So that's coming through more into the front line now. So some longer term solutions have emerged after that initial panic. So this is for a short introduction to Content Guru. So we are very much in the communications technology space. We operate a very large cloud platform we call Storm, and that runs services for many hundreds of large organizations, many of them in the healthcare sector. So you can see from all those flags that we're in lots of glamorous locations like California or Tokyo. Headquarters is in the less glamorous locale of Bracknell in Berkshire. And we're very much a British-centered company. We're part of a Redwood Technologies group, first established in 1993. And Redwood's background goes back into the days of TV voting for things like Pop Idol and Big Brother. So really it's about these communications at scale. What Content Guru did was married that up with complex communications, specialize in the contact center. So that whole customer experience field has bled through now into patient experience and patient engagement. So that's very much our core space, managing those communications for mainly large organizations, but lots of smaller ones as well. And the other part of our group is Western Digital, and they specialize in quality management, quality assurance of distributed operations. So that's things like screen recording, scoring, clinician adherence, performance management, that side of things. You can find us on most of the main frameworks. So we're on a number of Crown commercial service frameworks. You can find us on, for example, G-Cloud 12 or DOS4, on the Spark Dynamic Procurement System. You can find us on other things like Edge for Health or in the COVID-19 catalog. We're in the newer NHS frameworks, GPIT Futures and HSSF as well. So search for us via terms such as contact center or call center or video consultation, and you should soon be able to find our team. So what we do is patient communications for the healthcare sector. So you can see around the edges of this circle there, these are all the different means through which today's patient wants to communicate. So it's not just about the voice call anymore, because though that remains very important and is going to remain important, it's also about video, it's about IM chat. They might come in on Facebook, Twitter, they could come in through email, SMS text, of course, maybe WhatsApp. So it's that variety of mechanisms through which the patient wants to communicate with their healthcare provider. We run these kinds of services from our Storm platform. It's all up in our cloud. It's all secure, in keeping with all the top cybersecurity and other measures. So we run for national organizations, people like NHS Blood and Transplant, you can see there. In fact, we set up with them a national bereavement service during lockdown 1. Public Health England, we operate for Serco, the outbound track and trace calling system that's used by thousands of trackers. And that's been renewed twice. I think it just got extended again yesterday. So we've operated some of these national level services on kind of regional bases. We work with the likes of Healthy London Partnership, where our platform runs all traffic into 111 for the whole of London. That's across all 5 of those footprints there. We work with providers such as Hearts Urgent Care. They manage the 111 and out of hours services across 3.3 million people in the east of England. That's everywhere from West Essex and Hertfordshire through Luton, Bedfordshire, Cambridgeshire, Peterborough. So yeah, we work on either this kind of upstream basis for the likes of HLP or the full end-to-end basis for the likes of HUC. We have hospital trusts, big ones like Belfast Trust, smaller ones like George Eliot or Yeovil there. We've got mental health trusts, obviously you're going to be hearing from one today, others such as HPFT in Hertfordshire or NCHC in Norfolk or BEH in North London. We even do some patient transport and primary care as well. So for us, healthcare is a subset of our public sector practice. We operate critical national infrastructure for the likes of the Home Office, Department of Work and Pensions, Department for Transport, Department for Education, DEFRA, and we run the comms for lots of quangos and other organisations from UCAS through to the Rural Payments Agency or the Environment Agency. So Outside of public sector, we work with everyone from people like EasyJet and Ryanair or Arriva through to online big organizations like Trainline or Rightmove, retailers for likes of Morrison's, Tesco, Screwfix, etc. And some financial services organizations like AXA, PPP Health. So for us, healthcare is really important. It's a growing sector and one where we've been able to draw on our experiences in other markets and bring really great communication technologies to bear for the benefit of health. Storm is our platform. It's in the cloud. It's the largest of these types of platforms that there is. Within the UK, we're in 4 secure data centers and many others around the world. So we keep data sovereignty here in Britain. We offer limitless scalability. So for our customers, it doesn't really matter kind of how big their service is, we'll be able to handle it. So for example, in the early point of the pandemic, March the 13th, I think, was our peak date in London. The 111 service there, we were handling 500% of usual traffic volumes, but 1400% of usual durations. So effectively, we were operating as a buffer and a queuing mechanism for all of those downstream providers. For the likes of the DWP, Department of Work and Pensions, Universal Credit, that spiked to 50 times normal traffic, so 50 times the usual number of people coming in. We operated a 10,000 queue at one point. And actually, we were asked, can we make the queue bigger? The queue, just to give it some context, is normally about 15, 20 strong. So we said there's really no point having a 10,001 strong queue when you've got a relatively inelastic supply of call handlers. So the answer, of course, is intelligent automation. So taking people to other sources of information. And we did that for 111 as well. So we, as approved sources of information about COVID became available, then we would send a text and you'd be able to click on a link on that text and go through and get up-to-date information immediately. Or we would take you to an online form that you could fill in. So automation is very much key to the future, and we're doing a lot of automation around natural language processing, for example, for demographic capture. So we can find out who somebody is, reference perhaps a DASTRA, we can open a record, open a new case, and put that in front of a call handler so that they're ready to go immediately. We're experimenting now with using natural language processing for module 0 inquiries, so establishing the really urgent cases while they're still in the queue and prioritizing them and taking them through to a specially trained group of clinicians who can deal with them. So some of that IA rather, bleeds over into AI, so the artificial intelligence side of things. So we work with the likes of Google and with Watson from IBM. So they're kind of main hyperscale AI engines. And we are all about deploying those most appropriately in the service of patient engagement and generally communications from our cloud. Rich functionality, so not just the AI, but it means you can communicate over any channel. If you want to come in over WhatsApp or a Facebook page or whatever, you'll be able to handle that, or our customers will be able to handle that. We also integrate, for example, with clinical decision support systems. So in this rich functionality, you could perhaps have called a healthcare organization, you'll receive a text, you click through the link, you'll do some self-triage or symptom checker completion on a clinical decision support system. And then when we put the communication through, all of that information that you've self-entered on these forms on your mobile device, that's presented to the clinician together with some suggestions as to what the cause might be. And that leads into the last part, which is our integration capability. So whether it's things like a DASTRA that I talked about, or maybe specialist mental health around care notes or or Rio, or it's things like Coordinate My Care, which bring together a number of health and care information systems into one, or the likes of Patients Know Best, My Brain Book, NeuroResponse. We've done hundreds of these different integrations. And because we actually make all of the software behind our platform, integration is actually really easy for our team. We've got over 200 software engineers standing by to integrate with whatever homemade system you might have. This is how analysts view us. So this is the last Gartner Magic Quadrant for what we do. They call it CCaaS, Contact Center as a Service. And this is the final measurement of Western Europe on its own. In a Gartner Magic Quadrant, the y-axis, the vertical, is about your ability to execute. Can you do the things you say you can do? On the right is the completeness of vision. So how big is your story? And so you want to be in that northeast quadrant, the leader quadrant. And if you've got good enough eyesight, you can see Content Guru is at the upper section of that leader quadrant. This is just being replaced at the moment with a new global Magic Quadrant. Measures, I think, the top 13 organizations globally doing this in the cloud. And again, Content Guru is featured very prominently there. We're just waiting for Gartner to clear the slides before we can include those in our materials. Similarly, just after the Magic Quadrant comes the Critical Capabilities Report by Gartner. You can see Content Guru, and this is a global measure. In the last CCR, we're measured as being the top for high volume customer call center. So you might think, well, I'm not that high volume, but quite often you'll find that you are a very high volume call center, even when you didn't intend to be. You might be like a Healthy London Partnership, where suddenly you've got 14 times call capacity and you've got to handle that. So it's useful that you can call upon that. And many of our customers in other sectors, like think of UCAS on A-level results day, they depend on our ability to deal with these big surges of traffic for them. And actually in the new global CCR that's just coming out, again, we're joint top now for this high volume measure, along with Amazon, which is not a bad one to be alongside. All of that, and this is the last blowing my own trumpet slide, high growth. So we grew 25% in revenues last year, and at least that for the last 4 or 5 years now. It's all about sustainable growth for us. We don't do any loss-making business or anything risky. We're quite conservative in how we go about our business, but it's always about growing. And that's brought us a lot of awards. We've won a couple this year. And most years, often with our healthcare customers, we've won some quite prestigious awards, including UK IT Awards ×2, actually. We've got 2 of those. So that's it for the Content Guru part. These are the 2 examples I wanted to bring out about how we have worked to produce some of these longer term solutions. You'll recall a few slides back, we had 2 things. We had video and we had reducing queues. So this is the video side of it. So we call it Storm Link. So it enables you to use the customer's mobile device. So the patient has their mobile, either they're calling on it or you're able to send a text message to them. They click through and it turns on their mic, it turns on their camera, turns on their screen. If perhaps they're calling from a landline, you can email their iPad or their Android device or other tablet. Again, it automatically will open up the camera and the screen on that as well and pipe it through to you. So as a clinician, you've got visual access to the patient. Crucially, both parties remain at home. And again, you can have a secure, encrypted end-to-end session. So it's fully encrypted, so no one can break in and watch or listen to it. It's a one-time use link. So each time you send a link to the patient, it's unique. It can't be repeated. If they send it on and after they've used it, no one else can use that. Ease of use. All you have to do as the patient is receive, during the course of a voice call, receive a text message, click on a link in the SMS, and it does the rest for you. So you're not having to install an app, you're not having to make a booking, to do any kind of pre-session setup. It's going to work regardless of your Apple or Android or whatever your device is going to be. The ad hoc side of it, you can book these things, but more often it's useful to have a telephone consultation, and then you decide as a clinician that you want to upgun that to being able to see. So that ad hoc decision is in the hands of a clinician most of the time. So I think I would benefit on this call from having a look at that rash or seeing if that person needs to come into the hospital. It can be one way or two way. So the first launch of that was one way because they the customer didn't want patients looking into the home of their GPs. Now we can blur the background if we want, and also we have two way. Two way obviously builds extra reassurance on the part of the patient. And then obviously cost efficient because you just bolt it on to your existing phone-based dialogue. The other part is Storm Sign-In. So this is this scheduling tool. So it's moving on from a static appointment to something more dynamic. So it's about managing a queue digitally. So if you think back to our background doing call centers and contact centers, it's all about managing those queues. It could be a 10,000 strong queue of people needing universal credit. It could be a queue with just 2 or 3 people in it waiting to speak to a clinician. So therefore, when we map it onto a physical environment, and we're talking about queues of people waiting to get into ED or waiting to get into radiology, then we're obviously able to manage those in much the same way. So the idea here is you can start queuing while you're still at home, and you can continue queuing while you're in the car park, you're in the Costa. So just really delaying until the last moment, that point at which you walk in and are seen, and obviously crucially have a chance to catch things you might not want to catch. It's dynamic, so it will adjust. If you've got a rush of emergencies, then being a dynamic queuing system, it will push other people down the queue, and it will assign a priority level to each of the people that's queuing. But for reassurance, you get a comfort text, as we call it. So maybe every hour, every half hour, it's telling you that you're on track. We're still good for 3. It's slipping back a bit. Perhaps could you turn up at 20 past 3 for 3:30? So that's reassuring, and it's known then that, okay, they know I'm waiting, which is obviously one of the things that people worry about. And then, of course, one of the good things about a physical waiting room is that you can go out and have a quick look, see if people are deteriorating. Here you can communicate with them, you can talk to them, they can talk to you. So on those comfort texts, there's a number they can call, and that could go either to perhaps a 111 group, a clinical assessment service, or it could go through to your own facility. And of course, you could then invoke the option of a video consultation, being a Storm Link that we saw before. So for me, those are 2 potentially key services that you could bring in and bolt on to your organization. So I'm going to hand over now to Andy Lord. He's hopefully waiting, primed with his mic, ready to talk to us. Are you there, Andy?
Good morning. Yes, hopefully you can hear me now.
Yeah.
Afraid you can't see me, keeping that a secret, but the wonders of our IT systems in the NHS mean that that's not been possible. But really pleased to be joining you this morning. So
I'll push the buttons for you then, Andy. So if you want to get it started,
that'd be lovely. Yes. So what I'm here to talk to you about is the story of the Sussex Mental Health Line and how we've managed through the coronavirus pandemic so far. So the Sussex Mental Health Line is a 24/7, 365-day-a-year service which provides mental health support to anyone who calls. The service has to triage each call, determine the level of severity and complexity of those calls, and make a decision about what we will do with each of those calls. And we have our processes that we do that by, and the triage frameworks that we use, which are significantly different to NHS 111. But what the service actually provides is the ability for anyone to get that support at that low level, which prevents the escalation of mental health crises. Now, that is the kind of crucial value proposition that the service provides, in that we are able to, in the vast majority of cases, 90% of the time, in fact, manage somebody's distress over the phone, help them to manage that incident, and often linking back to the care plan that they have previously made within our trust in a different team or service, and come to some plan of how they're going to manage that immediate distress. In other circumstances, we can and often do link in with emergency services, so we will patch through, transfer to 999 if necessary, or indeed clinicians within our service. So we have our team is made of a larger team of support workers who provide that initial call handling, support and linking with people's care plans, but they can then transfer to our clinicians if need be as well. So in terms of what does the service, what value does it provide to the wider health system, the Sussex Mental Health Line, by being able to provide this preventative care, avoids people needing to turn up to A&E, which we know commonly happens with people with mental health presentations. So we've seen that we've been effectively able to reduce demand into other types of emergency services, and indeed our other urgent care mental health services. But obviously, so the service has been running for some 20 years. But in 2019, we wrote a business case to significantly enhance the service, noting that we needed to do more to get the benefits of reducing people attending A&E, attending our other urgent care services. The original plan in 2019 was to link with NHS 111, which is still our ambition. So, and the long-term plan was that people would be able to call 111, press option 2 or ask to be put through to the mental health team and be put through to our service. We're still working on that ambition, but through COVID, we've essentially beefed up the service internally and haven't quite landed that integration. But we'll come on to talk a bit more about that later. So I guess the next point really is what did we need to do differently, and what were the challenges that coronavirus has brought us, and what's that required of us? It was, and I'm sure many of the people in this webinar will appreciate, it was certainly a double whammy for healthcare, in the sense that we had a skyrocketing demand at the same time as a workforce that was destabilized. So we had all of our members of staff almost overnight wanting to be able to work from home. That was an enormous challenge. Beyond that, though, we also had all of the other services within the trust having that same problem. And what was quite remarkable was managers from across the trust were asking myself and others who work with the mental health line, can we redeploy our staff into your team? Because we can naturally see that they can do that type of work from home. So we had this monumental challenge of not only getting all of our own staff to work from home, but also to take on huge numbers of other staff from other teams, train them ever so quickly to enable them to continue to work, and to enable us to manage the increased demand that we saw, particularly in the first lockdown, but which has been sustained throughout. So moving on, really, what we have managed to do using Storm is is take on these new members of staff and train them remotely on our systems. And we've enabled people to log into Storm on either their trust PCs, on their personal laptops, and be able to log in securely and work from any site, albeit on our trust or otherwise. We have had some challenges along the road. We found that using Storm on our site, we had to do things slightly differently to if people were working from home. But now we've been doing it for a while. We're quite adept at getting people in and into the service quite quickly. A good example of that is we've recently been asked to build our resilience again for anticipated increased demand over winter. And to do that, we've trained 15 additional staff to join our bank, our bank pool of staff. And again, we've done that through training remotely and using the Storm platform to enable people to work through that. One of the other things that we've found is that using Storm, we've been able to understand our demand and the types of calls in far more detail than we have previously. And so we've actually been able to day by day look at our demand. And I mean, this seems like something quite rudimentary to probably most call center type services. But for us, that has really been quite transformational to be able to have at our fingertips the data that tells us the type of demand, the level of demand, and the time of day that it's happening, and that indeed the types of callers and where they're coming from has made a huge difference to the ability for us to match that demand with the capacity of our service and tweaking shift patterns and those types of things. So moving on further into kind of what we've done in terms of how we've addressed the problems that we've found. Obviously, we've implemented home working and used the cloud-based Storm. A little bit more about the business intelligence side of things. We've been able to do things like identifying our high intensity users. So we know that we have a group of people who frequently call our service. And we've been able to identify that through using the Storm's view platform, and then think about how we treat those people differently. How do we give them the support that they clearly need? And through doing that, we've been able to create bespoke care plans for those people that mean that they get the support they need, but B, that means they're not so dependent on calling the line as often as they were previously. And that's made a huge difference in terms of our ability to manage demand. One of the other things that we've done is linked care notes with our mental health line system, so that when we speak to somebody on the mental health line, it automatically updates care notes and emails the patient's lead practitioner, if they're known to a service within the trust, to say that we've spoken to the person and this was the outcome of the call and this is what we're going to do next. And we found that's really made a huge difference to how services can then take on board what's happening with people, because often clinicians who see people more routinely don't know that somebody may be entering into a crisis. So that's enabled a really useful early warning system for our clinicians to be able to tap into and help people before it gets to crisis point where they might need more intensive intervention. I think finally, in terms of clinical governance, I mean, this doesn't talk much to what we've done with Storm, I have to say, sorry, Martin, but it does talk to what we've needed to put in place in terms of how we've used our triage frameworks, how we've had to quickly train people in those, and all of the complications that that's brought. I suppose one of the things that comes on the next slide is some of the things that we've thought about doing next, and the chat functionality within the team is a good example of this, and how it links kind of with clinical governance. I mentioned earlier that we have a process of having support workers, and when they triage a call at a certain level, they need to seek the support of a clinician within our team. Historically, the way that they did that was they would try to transfer the call or have a discussion with the clinician first and have the patient on hold, Potentially the clinician would give some advice and they would go back to the patient, or they might transfer it through to the clinician. The challenge with that was that we have a limited resource of clinicians, and it was often, if they were on one call or all our clinicians were full, one of our operators got stuck looking for support. What we've got now is this chat function, and at the time of writing the slides, we were thinking about doing it, and quite quickly we've implemented it. And what that's meant is that the team are constantly chatting to each other over this chat function that's embedded within Storm, very much like WhatsApp or anything else like that. And they're talking dynamically constantly about the types of calls that are coming in between one another, and providing the peer support that you would naturally have if you were sat in an office together. But that was something that we really felt the difference of, with everyone working from home. How do you build that kind of team, that team nature, and that peer support that is naturally there? And one of the funny things about the chat function was that I found out about it and kind of got onto Storm to see if it was being used, and started asking people. And I was struck that people just completely naturally adopted it. They were using it far before I even knew that it had gone live. And beyond that, they developed a system for using it, like I've just described, of how they can contact clinicians and how they interact between one another completely organically. We didn't need to kind of through a management structure design anything. It's just happened. And that's something that I've not seen happen very often. It was quite interesting. I think going forwards, other areas that we're looking at is diversifying the way that we communicate with patients, and a lot of that we're trying to do that in collaboration with patients and understanding what would be most useful for them. And what we find is that it's different for different cohorts of people naturally. So I think, well, our longer term ambition is to be able to provide that diversity, so we meet the different needs of people that are coming and need our service. As I mentioned previously, we're also still looking at how we integrate with NHS 111 and indeed 999. At the moment, well, our process is quite simple in the sense that we will call 999 if we need to and transfer a case to them. But we are quite soon looking at processes where we can conference call 999 or 111 into a call. So we've got our practitioner, 999, 111 clinicians, and the patient all on the call at the same time, so that we can make a joint decision about what we need to do for somebody. Because particularly in mental health care, we find that it's very rarely black and white, and having a conversation together, we can often find that the best option and outcomes for patients. So I think that's most of what I had hoped to share, really. I'm really keen to hear if there's any questions, and will do my best to respond if there are any.
Yeah, thanks a lot for that, Andy. So some really interesting content there. And let's put the camera back on there. So I very much enjoyed hearing that. Some stuff I didn't know, which is good. So I think we're going to move on next to the poll results, and then if you want to keep firing your questions over to Andy and to me, then we'll address those after the poll. So the first poll was about which were the biggest challenges. Was it the need for immediate home working, the complexity of inquiries, the increased number of inquiries, or the need to reduce in-person contact in care delivery? So have we got Sean or someone available here to bring on the poll results?
Can you see the results there?
No, I can't actually.
Do you want me to read them out to you?
Yeah, let's hear.
Okay, so the immediate need for staff home working is 44%. The increased complexity of patient inquiries is 18%. The increased number of patient inquiries is 24%, and the need to reduce in-person contact in care delivery is 54%.
Okay, interesting. So that's very interesting. So two kind of big ones there then. The first was about reducing the in-person contact, and then the second was about the need for immediate home working at 54 and 44%. Andy, what do you think on that? 54% wanting to reduce in-person contact. Is that something that you've seen in SPFT?
Yeah, I would say that really reflects kind of our experience, really. I don't think you can underestimate the size of the challenge in terms of how do you deliver care remotely at scale. As I reflected earlier, the training elements and having to do that so quickly was a real challenge, certainly through the first lockdown.
Yeah. And then obviously, I think everyone in every organisation found this sudden need to work from home to be a big challenge. Even us, obviously, we operate everything on the cloud, but we were really an all in the office organisation. We started planning on the 13th of February for this sort of seemingly far out scenario. What would happen if we have to send 300 people home? And that was a real kind of big question that we put out there. And then in the end, it wasn't that bad. And I think, as you could see from my background, we're still doing quite a lot of it now. So let's have a look at the second poll. So this was about the limiting person-to-person contact. So it's interesting that the person-to-person contact, that was over half of you thought that was a big one, 54%. So here it's voice call consultations, video consultations, dynamic queue management, or those digital self-service options. So Sean, can we have a look at the results there then, or hear of them?
Yeah, so voice call consultations, 34%, video consultations, 55%, dynamic remote waiting room queue management, 7%, and digital self-service options for patients, 4%.
Okay, interesting. So again, a very clear standout there for video consultations. Again, I've worked about 25 years now in the communications technology industry. Video had always been, for nearly the whole of that time, the next big thing. And what we found was suddenly during the end of February and into the beginning of March, we were being called up to London a lot by central NHS, and they were wanting to talk about how quickly could we implement these video consultations. So we had everything demonstrable, but we saw it as too big a rush to bring it in before the first lockdown. So we kind of opted out of that process at great financial cost, as it turned out. It was some quite big prizes at stake, but we didn't think it was going to be responsible to rush through something as important as video consultations. So we held back a few weeks till we'd hardened everything off and we'd fully productized. And then we launched, after doing all the clinical safety cases and the data privacy impact assessments, we launched one-way video and then two-way video. So in the long run, I'm glad we kind of did it in that slightly more sane way. But yeah, there was suddenly this big rush to do video. I don't know, Andy, you don't really do a great deal of video, do you, at SPFT?
We do, but not particularly in the Sussex mental health line. We have adopted it more in our kind of more routine services as planned appointments. I mean, there is talk about whether we might consider adding video consultation to our police street triage services and being able to provide more remote support to police officers on scene and indeed paramedics on scene. We are looking into that at the moment as being a good model, purely because it's very difficult to anticipate the demand in those types of services. So it doesn't always warrant having somebody stuck next to the paramedic all the time, but having that ability to get it on tap when you need it is really useful.
Yeah. So I can't see the question and answer. I've had a few sent through on direct message.
Hi, Mark.
Sean, have you got any more you want to read out?
Yeah, you should be able to see the questions.
It's there now.
now.
Yeah. Okay, good. Right, so I've got one here from Kevin Foreman about supervising a student on a patient consultation. What do we think of that one, Andy? The supervision on a consultation.
Well, I can't see the full question, but so in
It's
terms of
written in fairly short form. Supervising a student on a patient consultation? ? A man of few words is Kevin Foreman.
well, brevity is good. I mean, in terms of what we're doing in the mental
He's
health,
actually added to it, Andy, while we're talking. So he types fast as well. So e.g. a primary care consultation where the student would normally be in the same room as a clinician and the patient, where the student now can't attend physically and the patient is at home. So I guess that's kind of bringing on a less experienced person and supervising them, or enabling somebody to learn by watching an experienced clinician at work.
yeah, I suppose in terms of our experience, particularly with the mental health line, we have done things like all our calls are recorded, and we've been able to create a bit of a bank of useful calls to listen to as a learning experience. That's been quite useful. We also have the ability for people to listen in on calls, and we've used that as an induction process for people coming into the team, so that they can listen in, shadow people as you would do kind of face to face, and then gradually kind of take on more responsibility as you would do as a student. I think it's different, I suppose, if you're doing that as a full-time student. I think you need a blend of different approaches to get that learning, don't you? But that's some of the things that we've put in place.
Yeah, and someone else, Amanda Grossman, has said the issue with video calls is not the video tech itself, it's the proper integration with the Trust EPR to ensure the activity is captured appropriately. So Andy, have you done anything about the patient record integration, or are you saving your video consultations, or are you just writing about them?
I believe we're writing about them separately, but I know what the Trust is doing is using our video consultation platform to provide the data around those types of contacts, and then expecting clinicians to also input that onto our care note system. So we can look at those two and triangulate the data.
Yeah, and then there's a question about FHIR integration. So FHIR is HL7 FHIR, certainly something we're working with as a standard. I don't know if that's sort of crossed your radar as yet, Andy.
I don't think so. No, that's probably.
It's an interoperability standard, so it's emerged out of America. So initially it was for patient record interop, but it's kind of a useful standard now, for being able to do lots of lookups and potentially writing into a record as well. So it's got certainly some implications in the longer term for perhaps some of these automated services and updating the record that those services have been delivered or that an interaction has taken place. So it's probably something you'll hear more of later. Let's see with some other questions. Have we got any partnership working with the North 3 region, Lancashire and South Cumbria? Well, probably on your side, you're pretty much about your area, Andy. So from our side, yes, we do have some discussions going with Lancashire, certainly. Those are actually being led by our medical director. So Anjum Shahzad, if you want to get in touch with us or maybe we can find you. I can put you together with that. In fact, one of the very last meetings I had, I think probably the last one before everything stopped, was up there. And actually, there's some interesting work that they're looking to do of bringing together mental health and police services. I know actually on that front, that's something, Andy, that SPFT have got a police dialogue going, haven't you?
Yeah, we have our police street triage services, and as I mentioned, we are considering whether we add a video element to those.
Yeah,
so,
I think this was about a 101 to mental health trust transfer in particular. So yeah, that's something that is actually cropping up in quite a lot of areas, because many calls to police, particularly 101, but also 999 to an extent, are really best served by mental health professionals rather than police. And certainly in London, we're working on a pan-London project at the moment, and that's aimed at reducing numbers of Section 136s, for example, that police are handing out, by bringing in mental health professionals much earlier on, either on the street, as Andy was talking about street triage, or because somebody has contacted a police telephone service.
yeah, just to mention, we are looking at that, certainly for 101 for the police as well, so that they would be able to warm transfer to our service, so that it would, like I described with 999, they'd be able to talk between the two services and then transfer the patient when they felt they wanted to.
Yeah. And then there was a question, another one from Amanda Grossman about sign-in, which was the virtual queuing, and how's that been integrated. So initially that was deliberately developed as a standalone, because we spoke with the Cerners and others, and whilst we could integrate with them, we thought the priority was to produce something that would work. And obviously the first bit of integration we're looking at doing is with Eddie, so that we can receive those emails to make a booking, and we make a static Eddie booking into a dynamic appointment booking. So we've only got a couple of more minutes left, so let's rattle through a couple more of the questions. Another one from Kevin Foreman. Can link be used by a clinician supervising a student on a patient consultation? Yes. So if you're on a video consultation, then there is a supervisory ability in there as well. And also you can use screen recording to evaluate offline as well, so you don't have to physically be there. Just like with a lot of the phone services, very often you're looking retrospectively. And again, things like natural language processing are increasing our ability to be able to see what people have said in text form and make that searchable. So what else have we got here?
There's a few questions up there, Martin, as well, for you, if you can see them.
Okay, well, there's a lot of questions, which is good, but kind of running out of time. So within secure environments, in cell phones have developed quickly, says David Chin, sorry, David. In cell phones, we're talking in prison environment, I think here, are we? Next would be the use of tablets and possible triage through a consult and consultations to secondary care, patient health promotion and musculoskeletal medicine with advice. So yes, there's definitely a lot further we can go with all of this as well. So unfortunately, that pretty much uses up the rest of our time. Thank you very much for joining us. It's been a pleasure presenting with Andy and also our Convensis friends. Any questions for us at Content Guru, drop a line to the PSH team, Public Sector and Healthcare team at contentguru.com. Or find us, come to our website, you can chat with us, where we use some of our own technologies, we'll be pleased to hear. So we're easy to engage with, as indeed is our strapline, engagement made easy. So I'd like to thank you all. I know you've all got your 12 o'clocks to move on to, and it's great nearly all of you have been able to stay for the full hour. It's been a pleasure, and